Welcome back to Clinical Problem Solving. We are on Module 2. I hope that you were able to complete the homework and found it interesting and useful to apply the information we presented last week. We'll start with a brief review of Module 1 and then move quickly into some new concepts for Module 2 as we help you develop your expert problem solving. Once again, I want to thank my collaborators over the years and start with our Module 1 review. We talked about the importance of not only understanding what information goes into a clinical problem-solving exercise, what diagnosis comes out, but what is actually happening in the brain as good clinical diagnostic efforts are being put forth. We talked about the clinical problem-solving paradox, that as people mature in their clinical problem-solving skills from novice to experts, they increase their diagnostic accuracy while decreasing the amount of data that they gather. This is an exercise in efficiency and effectiveness. And we're going to continuously remind you that the development of sophisticated problem-solving skills involves not only an increase in the number of facts that you have in your brain, but a change in the way those facts are stored and used. Last week, we talked about compare and contrast thinking, realizing that when we know a disease, it's not sufficient to know about that disease in isolation. We have to understand how it compares, both in terms of clinical presentation and mechanisms of action, to other diseases that might cause the same type of symptoms and signs or syndromes in our patients. And we introduced the concept of illness script, which is the package of information that experts use to store knowledge about specific diseases within their brains. All of these connected in an intricate neural network that allows the expert to compare and contrast easily when patients present with symptoms that might suggest one of many diseases. We hope that you remember that the four basic components are epidemiology, who gets the disease, time course, how does the disease present with respect to time, clinical presentation, the classic signs and symptoms that are unique or representative of this disease, and mechanisms of how the disease occurred, whether pathophysiology, abnormal anatomy, or exposure issues. So, let's go back to Jeremy Leder. You remember Jeremy. We introduced you to him last week. He's 15 years old, and he is here with a very sore throat. Jeremy hasn't felt well for about 3 days, but has felt really sick for 24 hours. And in addition to his sore throat, he's had fever, fatigue, and a general sense of malaise. He's had no cough or stuffy nose. And on physical exam, he has a significant fever, a temperature of 102 degrees Fahrenheit. His heart rate is mildly elevated, blood pressure normal for age, and he has no evidence of shortness of breath or tachypnea. His exam is notable for bilaterally symmetrically enlarged tonsils, which are quite red and have a nice white exudate on both of them. There are no other mouth lesions, but he does in fact have diffuse cervical nodes in both the anterior and the posterior chain, as well as some axillary nodes and an enlarged spleen. So let's look at a partial compare and contrast reading chart for pharyngitis with regard to Jeremy's possible diagnoses. Remember, we always start with a syndrome, one of those common reasons or common ways in which diseases present in all humans. And these set of diseases, group A strep pharyngitis, EBV infection or acute mononucleosis, and acute retroviral syndrome, may all present with pharyngitis. And then what we have encouraged you to do is, rather than reading horizontally about one disease at a time, instead read vertically, where you can continuously compare and contrast different elements of these disease illness scripts with each other, so as to develop a nice, strong knowledge network into which you can slot new information. So let's look at what this might look like if we're looking for differentiating and key features. Well, Epstein-Barr virus infection does occur in 15-year-olds. Remember, Jeremy is 15. And 15 is just at the upper limits of age range for group A strep pharyngitis. Isn't that interesting? So we're beginning already to see a little bit of a difference here. There is no real age-related phenomena for acute retroviral syndrome, but there has to be a history of high-risk sexual behavior, which we haven't seen thus far in Jeremy, and we'll presume that the physician asked about that Now, interestingly, group A strep pharyngitis, from a historical perspective, usually presents fairly acutely, so less than 4 days. Once strep throat has been going on for more than 4 days, the symptoms begin to abate. So a longer duration might suggest that the disease is not group A strep pharyngitis. Importantly, and this comes from a famous set of criteria known as the Center criteria, group A strep pharyngitis has no cough associated with that. And that helps distinguish it from the common non-EBV or HIV-associated viral pharyngitis. Epstein-Barr virus infection, in contrast, can present acutely. It can present within a couple of days. But if the symptoms are present for more than a week, that's going to favor the diagnosis of Epstein-Barr infection rather than group A strep pharyngitis. And acute retroviral syndrome may happen acutely, but again, like Epstein-Barr virus syndrome, is going to occur and last more commonly for weeks rather than for days. So already you can see in this element of the illness scripts, there are some important distinctions. If the symptoms have been present for a week or more, that pretty much excludes group A pharyngitis and is going to make you look more closely at EBV or acute retroviral infection. On the contrast, if the symptoms have been present for a short period of time, it could occur in any of these three diseases. Now let's look at physical exam and see if there are any differentiating or key features there. Well, this is interesting because there are some really important differentiating features here. So for instance, both group A strep and EBV infection have exudative pharyngitis. There's white spots and white coating on tonsils in both of these two conditions, but not in this. Again, another opportunity to remove one of our differentials from the differential diagnosis list. If the patient has white coating on their tonsils, that makes acute retroviral syndrome very unlikely. Importantly, too, posterior cervical adenopathy is most common in this group of three entities to Epstein-Barr virus infection. And remember, Jeremy does have nodes in the posterior cervical chain, so we're beginning to get an idea of where we might be going with his most accurate diagnosis. And then there are some lab tests that allow us to confirm or refute our diagnoses after we've made them clinically. A rapid strep test is only going to be positive in group A pharyngitis. Atypical lymphs and a lymphocytosis in this constellation of three diseases really means the diagnosis is Epstein-Barr virus. This is a key feature in this diagnostic triad. Lymphocytosis, no lymphocytosis, or lymphopenia instead is a key feature for acute retroviral syndrome. But we've had some other key features. No cough, group A strep pharyngitis, posterior cervical adenopathy, Epstein-Barr virus infection. So that's what a compare and contrast reading chart completely filled out accurately would look like. There's another way of comparing and contrasting in a different visual way, and that's using the Venn diagram. And depending on the way you think, some people prefer this method of illustrating what is a key and a differentiating feature for each of these three conditions. So we start off, of course, with the syndrome in the center. That's pharyngitis, sore throat. And then we look for some differentiating features. Well, exudates on the tonsils, as we mentioned, occur both in streptococcal pharyngitis and infectious mononucleosis. Lymphopenia is a key feature. It only occurs in acute retroviral syndrome. Atypical lymphocytosis is a key feature. It only occurs in Epstein-Barr virus infection. But there are some things that acute retroviral syndrome and infectious mononucleosis share. For instance, both of them can cause a diffuse maculopapular rash. Both of them can cause hepatitis and other organ system involvement. But streptococcal pharyngitis doesn't cause hepatitis. So it's just another way of visually representing the compare and contrast thinking that we are encouraging you to seek out as you read about different conditions and diseases throughout the course of this course, as well as throughout your study of medicine going forward. So, based on what you know, what is Jeremy Leder's most likely diagnosis? Is it acute streptococcal pharyngitis? Is it infectious mononucleosis? Is it non-Epstein-Barr virus viral pharyngitis, the common cold, or is it acute retroviral syndrome? The preponderance of evidence suggests that it is acute infectious mononucleosis. What makes it so? The posterior cervical nodes, the presence of axillary adenopathy and splenomegaly, which don't occur in the other entities, and his age group. And in fact, Jeremy Leder's diagnosis was infectious mononucleosis. His rapid strep test was negative, his monospot test was positive, and he was sent home with instructions for fluids, ibuprofen, rest, and no contact sports for 6 weeks to protect his spleen. How did you do?